presente la doctora Magda Turner la presentación en infecciones cerebrales, de la imagen al patógeno. Y los invito a otra sesión excelente. Avanza, go forward, go backward, and this is the, no, not that one. This red one, little line there is for the pointer. Okay. Yeah.
Buenas tardes a todos. I'm very happy to be here today. I would have loved to give this lecture in Spanish, but I think my Spanish is definitely not good enough. I can understand something, maybe later for questions, but I will have to answer in English. So my topic today are CNS infections. Actually, how do we get with imaging from image that you see directly to the pathogen, basically to the final diagnosis? And I would like to teach you on this one. If you look at these 6 different patients, but each time you will see a ring-enhancing lesion. Well, this one is relatively ugly, this one also, this one, but at the end, they ended up to be infectious lesions. If you look at these are smoothly and nicely pacificating ring-enhancing lesions that ended up to be neoplastic lesions. Let us look at 6 other cases, all ring-like enhancing lesions, all different diagnoses, going from brucellosis, toxoplasmosis, aspergillosis, or cysticercosis. So one thing is clear, if you look at this patient, you cannot rely on enhancement to make the final diagnosis in ring-enhancing lesions or brain abscesses. So what should we do? To be very good in diagnosis, you need a thinking cascade. You need your brain to answer certain questions one by one. This is what I call step-by-step approach in diagnosing ring-enhancing lesions. So the very first question that you have to ask yourself is, am I talking about an infectious lesion or is this a tumor? Once you decided this is not a tumor that I'm looking at, this is an infectious lesion, then you have to ask yourself questions. Is this just a bacterial abscess? Is this a fungal abscess? Could this be eventually tuberculosis or maybe even parasites? And at the end, the last question that you should ask yourself is, could this eventually even be a demyelinating lesion, not even an infectious lesion? So let us start with the very first question. Is this ring-enhancing lesion an abscess or necrotic tumor? You have 4 different techniques which you can use to answer these questions, or if you're doing a very long MR protocols, all 4. So either you use diffusion, which I always say it's the cheapest and the shortest one, the easiest one, or spectroscopy, which is certainly complicated, perfusion, or even SWI. Let us look one by one. This is a pyogenic bacterial abscess. Not all of them will look so nicely as this one. This would be like a bookcase. Bookcase because the imaging finding exactly represent the pathology. We have a necrotic center, which is high T2 signal intensity. We have a T2 low signal intensity capsule that has 3 layers, which consist of collagen, but also a very thin layer of neovascularity. Surrounding, we have a relatively prominent perifocal edema, and after gadolinium injection, we have a smooth and nice enhancement of the capsule. Not all abscesses will look like this. So the first technique that we could use to distinguish abscess from necrotic neoplasm will be diffusion. A bacterial brain abscess has restricted diffusion with a low ADC. So basically, 90% of them will look like this, be very bright on DWI with low ADC. The reason for that is, of course, highly viscous content of the abscess cavity, which enables brain water molecules to move freely. So let us show you 2 patients. Both lesions are in occipital lobe, both are ring-like. This one has maybe more edema than this one, but you can definitely not count on that. Then you do diffusion, very bright on DWI, low ADC, that is a pyogenic brain abscess. Completely other story, this is dark on DWI, high ADC, this is metastatic disease. This rule apply about 90% of the cases, but still there will be possibilities to make mistakes. Be very careful with hemorrhagic metastasis in a subacute stage. they will also give you this high signal on diffusion. So be sure that you're not only looking at diffusion-weighted image before you say the final word, be sure that you look also at T2 star, gradient echo, SWI, whatever you have, to be sure that you're not mistaken hemorrhagic metastasis for pyogenic brain abscess. The other possibility to make mistakes are hypercellular metastasis. This is a very nice case of my Belgian colleague on this small cell lung carcinoma metastasis, which was very bright on diffusion, having a low ADC. This is just a colored map and a peripheral enhancement. So any kind of hypercellular metastasis might give you this high signal on diffusion. So, other words, if you have a patient with multiple ring-enhancing lesions, which are all positive on diffusion, so consider brain abscesses, but still maybe more likely is that this patient will have hypercellular brain metastasis. Let us add now perfusion-weighted image. So now this is ring-enhancing, diffusion positive with low ADC, diffusion restricted, low ADC. So now on perfusion, you might have two situations if you look at the pyogenic brain abscesses. Either will be completely low RCBV, low perfusion, or you might see a very thin rim of high perfusion. If you remember what I said on the previous slide, pyogenic brain abscess has a very thin layer of neovascularity in a collagenous capsule. So it's okay if it's very thin on this RCBV map, but it should never look like this one. This is a necrotic GBM. You see the red parts with increased perfusion at the periphery are much brighter, they are much bigger, they are much more extensive. So this is a necrotic tumor. Let me show you two cases. Just an example. This is a simplified approach, of course, to these lesions. Ring enhancing, this is restricted diffusion, negative perfusion. Tumor, which more peripheral and ugly enhancement, elevated diffusion, and positive perfusion at the periphery of the lesion. Let us move to SWI. Professor Parizel just have shown you how to use SWI for traumatic lesions. One can actually use SWI also for infectious lesion. And why is that so? So this paper came actually 2012, already a few years ago, when they tried to differentiate pyogenic brain abscesses from necrotic glioblastoma by using SWI. So this dark rim that we're seeing in the lesions is more likely to be smooth and complete if we have a brain abscess. And it has two layers, which are called dual rim sign. So almost all, 9 of 12 abscesses had a dual rim sign. So the dark one is the outer ring, and the white one is the inner ring. Glioblastoma never looked like that. They never had the dual rim sign. What they did have, they had like dots and lines representing neoangiogenesis or hemorrhagic lesions. So it looked very different. Let me show you one of my cases. This is an abscess in the posterior fossa, typical appearance on T2. T1, let's call it mother abscess and daughter abscess, negative perfusion, restricted diffusion, low ADC, and then dual rim sign consisting of two layers. The dark one is the outer one, and the white one is the inner one, and it goes all around. When I first read about that, I thought but why would that be so? Why don't we see this in other imaging? As Paul said, what are we actually seeing at this SWI? Well, if you would do very nice and high quality T2 weighted image, you would also see that the capsule has several layers. So these are patients where I saw the dual rim sign, and I put a T2 on the other side, on the left side, to see the capsule and these several layers. Let me show you a GBM case. This was a multifocal GBM with several lesions. Again, typical appearance, elevated diffusion. The periphery has a very high RCBV, again, positive on perfusion, and then this SWI, which shows you dots and lines. And now if we put an abscess and necrotic neoplasm right next to each other, we can go one by one. Both will have a ring-enhancing lesion. Diffusion will be restricted, diffusion will be elevated. Perfusion will be negative, perfusion will be positive. Dual rim sign and black dots and lines. So now these are just two slides that you will also have to download. These are key points in a pyogenic brain abscess. Remember, typical bacterial pyogenic brain abscess will have a low signal intensity capsule on T2, which will be seen as a smooth, complete rim on SWI. It will have peripheral enhancement, which will not always be nice and smooth. It will be bright on diffusion with low ADC due to diffusion restriction, homogeneously bright, and it will have low RCBV. On the other side, we will have a necrotic GBMs and metastasis. They will look also ring-like sometimes, but they will have peripheral enhancement and edema. They will be dark on diffusion with high ADC, inhomogeneously. They will have a high RCBV, especially in enhancing tumor parts, and they will not have complete rim on SWI. They will have some dots and lines. So now we answer the question when we're looking at the ring-enhancing lesion, is this infectious lesion or is it a tumor? Now let's say we decided this is an infectious lesion. So now the question is, can this ring-enhancing lesion be a fungal lesion? I don't even have to look at imaging. I can answer this question basically by asking another question to our clinicians. Normal immune competent patients don't necessarily get fungal infection, except cryptococcosis. Normally, patient to have a fungal infection needs to be in immune compromised state. So the very first question that you ask is this patient having any kind of immune compromised situation after bone marrow transplantation, after organ transplantation, or maybe this is an HIV positive patient. If you don't have this information and you will have to answer these questions based on imaging, then you do not need any advanced techniques. You can't distinguish bacteria from fungal if you use diffusion-perfusion spectroscopy. You have to know something about the fungal abscesses to be able to diagnose those. And the very first imaging characteristic of fungal abscesses is their low T2 signal centrally, exactly the opposite than bacterial abscesses. This is a bacterial fungal abscess, and this also. If you now go back at the T2 weighted sequence, the enhancing part is very dark on T2 with bright edema. The enhancing part is dark on T2 with edema. The other characteristic of fungal abscesses, which is not something commonly seen in bacterial abscesses, is their hemorrhagic nature. This is a patient with aspergillus. This is a patient with aspergillus infection. This is solitary hemorrhagic abscess on the left side, and this patient has several hemorrhagic lesions. Some of them are ring-like, and some of them are dot-like. So why would that be so? It must be an explanation. Why would fungal abscesses be hemorrhagic and bacterial not? The answer is angiotropic nature of fungal organisms, especially of aspergillus. What does it mean? The infection does not start in the brain parenchyma as it is in bacteria. It's attack to the vessels. What happens is we have invasion of the arteries and veins. These red things, red branches, are arterial structures, and the green dots are actually fungal organism. Or this one looks even better. It is something as you would look into the vessel inside. So now these green branches looking like asparagus are actually aspergillus organism, and these are erythrocytes. So it starts with attacking of arteries and veins, and then you have thrombosis, and then you have hemorrhagic infarcts, and then at the end you have a fungal abscess. So that's somehow logical, especially for aspergillus, that they will be hemorrhagic right at the beginning. The third characteristic of fungal abscesses are microabscesses, and this is especially true for Candida. So these abscesses can be so small that it's very difficult to see them. They're not even ring-like. They're real little nodular enhancing lesions in the middle of the brain of white matter. So if you see small abscesses, if I correctly remember, this is also true for other organs, then think of a Candida abscess. Sometimes these immune-compromised patients will not be able to even produce enhancement. So sometimes you will have fungal infections without seeing any enhancement, and this is certainly for us a very difficult situation. This was a case that we missed many years ago, so it's a nice teaching case. You always learn the most from cases that you actually were not able to diagnose. So this was an HIV positive patient in the early stages of infection. He had these several signal intensities, especially let's call it in the middle of the brain, but also somewhere else, completely non-enhancing. So for us at that time, it did not look like toxo or lymphoma. So what is the radiologist doing when you don't know what to say? Well, you say follow-up imaging, right? This is follow-up imaging 3 weeks later. 3 weeks later, this is getting bigger, but still not enhancing. But what have changed on T1, this became hyperintense. So these were hemorrhagic lesions in invasive aspergillosis, and this patient unfortunately died, and we learned the lesson. So the lesson is, even if things are not enhancing, in very severely immune-impaired patient, you will have to put fungal infection in the differential diagnosis. I already told you that you cannot use diffusion, perfusion, confusion to distinguish fungal from bacterial. Look at diffusion-weighted imaging fungal abscesses. It can be low, it can be intermediate, or it can be high, depending on the content, how highly viscous the content is. So this is a fungal abscess which definitely looks like bacteria, homogeneously bright, low ADC. This is invasive mucormycosis, which will also be very highly, have the high signal on diffusion. But we can go further. We are not looking at the content of the abscess. We should look at the wall of the abscess. This was a very nice paper describing so-called intracavitary projections. It's not maybe a very nice name, it's not a catchy name, but the point is we should look at the wall of the abscess, of this fungal abscess, which is bright on diffusion, low on ADC. What does it mean? These are actually fungal organisms sitting in the wall of the inner zone of this wall, and they will not enhance, but they will produce this mucoid material. So sometimes you will have to look at the center of a ring-enhancing lesion, and sometimes you will have to look at the wall. Let me show you some of the examples. This is a proven fungal abscess, ring-enhancing. Sorry for this, I will go back. I think ring-enhancing. It is shows elevated diffusion, so low signal diffusion. But then looking here, it's very bright, the wall, not all around, but here. This was a fungal abscess. Can I use maybe SWI to distinguish? I have done a small study with one of my residents looking at the SWI bacterial and fungal abscesses. Bacterial abscesses almost always show the dual rim sign. Fungal abscesses never showed a very nice dual rim sign. They were looking more like tumors. They had a very thick black rim, like this Aspergillus patient. We only had a small group of patients, so I'm not sure if this is completely true. But in this small group, fungal were looking very different than bacteria. This is another case of this organism. You see, this is a lesion that is very irregular, but still ring enhancing. And if you look at diffusion, the wall has a restricted diffusion with certain parts here obviously representing fungal organism. And looking at the SWI, you have a little darker rim, but you don't have a dual rim sign. So it looks very different. This is my summary slide on fungal infections. They are central hypointense on T2. So even if you don't have diffusion, perfusion, anything, at least you have T2. So if somebody asks you, is this fungal or bacteria? The first sequence that you should look at is the plain T2 weighted sequence. No enhancement will be common. Think about immune-compromised patient, especially bone marrow and organ transplant patient. If it doesn't enhance, it can still be fungal. They are hemorrhagic. They love cortex because cortex has more blood than the white matter, and if they love the vessels, they will go to the cortex. Microabscesses in candida infections, intracavitary projections, and a thick black rim on SWI. So now we move. Now we know how fungal abscesses look like. Let us look at tuberculous infection, which is increasing everywhere. Well, this is a little tough. Depends where you live. In certain area, in Asia or maybe Africa, everything is tuberculosis. Where I live in Vienna, tuberculosis is the last differential diagnosis of ring-enhancing lesions. We do have tuberculomas. They will be caseating. These ones are the ones that I always memorize because they're looking like fungal. They're dark on T2 and ring-enhancing. Problematic ones to me are non-caseating tuberculomas because they have nodular enhancement. They can be very small and have a T2 high signal. So you see, it's difficult on sequences. This is an example of a child with multiple caseating tuberculomas in posterior fossa. They're extremely dark on this T2, extremely dark on flare, ring enhancing, and had elevated diffusion. This was a young patient that actually the diagnosis was missed in a small outside hospital. She had only 2 nodular enhancing lesions, one here and one here. And to be honest, who would diagnose tuberculosis based on no meningitis, nothing, just 2 nodular lesions in the brain? I think all of you would primarily think this is probably metastatic disease, and we're going to look for a primary tumor. But actually nobody read the clinical history, and the clinical history were very typical, with fever, with night sweat, a young individual. I think we still should have thought about tuberculosis. This patient came into University Hospital, and see how it looks like now. Now there is a full picture of CNS tuberculosis, and I think we should have thought about tuberculosis infection right here. So this is also an example of a tuberculosis infection, what all we should see. So it's not about the ring-enhancing lesion. You have to diagnose all this. So meningitis were a thick meningeal enhancement, predominantly in the basal region of the brain. Then we do have a hydrocephalus. Then we have infarcts, usually in the basal ganglia. We have these tuberculomas and a perineural spread. This is a full picture of CNS tuberculosis. In some studies, they have shown that spectroscopy, I'm not going to torture you with spectroscopy. I think this is the most complicated way to diagnose infections, but still, as diffusion is mostly elevated, but may even restrict, they say in a questionable cases where you really don't know what to do, if you have the possibility to do spectroscopy, then this would be a good choice, because in these abscesses, you will see a large lipid peak. So this is key points for tuberculosis infection. Tuberculosis has a basal meningitis, infarctions in the basal ganglia, usually on both sides, hydrocephalus. These tuberculomas, which will be dark on T2 if they are caseous. We have to be careful about nodular regions, and if we have questions, we should do spectroscopy. Okay. We are moving further to parasites. I'm almost embarrassed to teach you about parasites and these infections because you are certainly much better than I am. But I will just go over it so you have seen all ring-enhancing lesions together in one lecture. What I might see in Vienna, it's still toxoplasmosis. We used to see toxoplasmosis early 90s when we have HIV patients, but still we will see these patients because patients who don't know that they're HIV positive might present with toxoplasmosis as a first manifestation of their disease. And this is such a case, you see multiple lesions, and sometimes you think like this could be anything. So you need something, you need a little keys. When I'm saying something is toxoplasmosis, well, when I see target looking like lesions, like this one, having almost several layers. This one is a real typical target, this one is atypical. Perfusion, of course, will be negative because it is an infectious lesion. This sign has been recently rediscovered, and it's called eccentric target sign in toxoplasmosis. This is this target lesion with a line which is not in the middle of this abscess, it is on the side, and this is called eccentric target sign, and we know what it is. And why do we have this line? This line is actually thrombosed venous structure. The only problem with these signs is that we will only see it in 30% of the cases. Other words, if you see a patient with multiple lesions in the brain, maybe one of them will look like eccentric target sign, and this will be enough to make a suspicion. This is one of my cases. You see this patient had several lesions, but then one, I think I'm being a little bit fast. Let me see how do I get back. Sorry for this. Okay, I'm here back again. Okay, this is this eccentric target sign. Look at this, a ring lesion and then a line here. So next time when you see it, I'm sure you will remember it. And then every time then you open some papers, you will see new signs. So this was kind of a little bit confusing to me. Now this is called concentric target sign. First you memorize eccentric and then they publish concentric. Okay, but this is different. Why is it different? Because this is not on T1 with gadolinium. This sign should be seen on FLAIR. So if you see on FLAIR several layers, looking a little bit like below concentric sclerosis, just to put two things together so that you can memorize it, this is also very suggestive of toxoplasmosis. So this is just, again, my summary slide on toxoplasmosis. T2 is not helpful. It will be hyper or hypo. This patient will also sometimes not show enhancement, especially in bone marrow transplant. They can also be hemorrhagic. Diffusion is not helpful. The helpful are signs, You will remember eccentric target sign and concentric target sign. If you do nuclear medicine studies, there will be no uptake and it will have a low perfusion. Neurocystic cirrhosis, again, you know much more about this than I do. For me, this will be very exceptional diagnosis, probably somebody who is traveling. When I used to live in Miami, ring-enhancing lesion was the first diagnosis, was always neurocystic cirrhosis. So it's very difficult if it's in this stage, colloidal vesicular stage, because there will be ring-enhancing lesion. It's for me very difficult. It's a little bit easier if I see this, of course, cyst with the dot sign. This is what I teach my residents. Multiple rings in the brain with the dot sign is cystic cirrhosis. And this is what Lara Brandao from Brazil borrowed me this beautiful slide, saying that if you use Fiesta on their machine or heavily T2 weighted thin sequences, you will be able to see the scolex and you will have no need for any advanced or sophisticated techniques. And you can tell me later if you agree on that. So these dark things inside represents scolex. Echinococcosis, again, is also not so common. Cystic echinococcosis, it's easy. I think the liver imaging would say a big cystic lesion in the liver is cystic echinococcosis, the same in the brain with CSF intensity and very thin wall. The problematic one would be the alveolar echinococcosis. That's a little tough, because they are multiloculated, they show strange enhancement, calcification, can be solid or semi-solid. Let me show you this one. This is clear, cystic echinococcosis or Hidati disease with a big cystic lesion in the middle of the brain, non-enhancing. This was a patient with alveolar echinococcosis, which again we were not able to diagnose so easy, but fortunately he had the biopsy of his cardiac lesion and ended up to be alveolar echinococcosis. So very dark lesions on this flare, located even intraventricular in the brain parenchyma and having this type of grape-like enhancement if you want. So imaging signs are very helpful. I know, again, this is a very simplified approach, just to put all the ring-enhancing lesions together. So cyst with the dot sign is cysticercus, eccentric target is toxo, and grape-like cluster would be alveolar echinococcosis. Or arborized pattern would be schistosomiasis, non-enhancing cyst in the brain is cystic echinococcosis, and sometimes all the other abscesses, like this one target looking like was amoeba infection. The last question or the last diagnosis of a ring-enhancing lesion, when we excluded tumors, we excluded all kinds of infections. Sometimes a ring-like lesion can be a demyelinating lesion. Let us look how can we diagnose this one. Multiple sclerosis can be a ring, enhancing ring, which is smooth and nice and complete. This we call closed ring. And now, sometimes, if obviously inflammatory component is so prominent, this enhancing ring might show restricted diffusion with a low ADC. So, other words, if you see a ring enhancing lesion which has a restricted diffusion in the enhancing part besides the fungal abscess that you remember, this could be a closed ring in multiple sclerosis. This is also very typical for tumor-effective demyelinating lesion, and this is called open ring sign. So this multiple sclerosis lesion or demyelinating lesion can be as big. They will show a ring which is open, not completely closed, and always open on the cortical side. You might see this in very small lesions and in very big lesions. And sometimes it's going to be really difficult. What else should you look to exclude demyelinating lesions? I'm not sure if you can see this, but this is a very thin black line going across this ring-enhancing lesion. What is this thin black line? Well, this is an intramedullary vein. We know that from our high-field studies. This is a 7 Tesla image. So there is this dilating vein going through this ring-enhancing lesion. You might see one, or you might see multiple of these lesions. If you see that, then you should think about demyelinating lesion. This is a case, you see this lesion, it's a ring, it's a bright on T2, it has a dark rim, it has some kind of halo-like edema, it has nothing really here, it's very difficult, but if you zoom it and if you pay attention, as Paul would say, you don't know, this SWR is so great, you see so many things, and now we have to figure out what that is. So kind of like, I love this to be this intramedullary vein running through the lesion. So this is a key points in a demyelinating lesions that can be ring-like. They're, of course, high on flare and T2. They're oval or ring shape. They have elevated diffusion, low perfusion, of course, and they have dilated veins. Sometimes they're running through the lesion. And don't forget the open ring sign. Okay, so you have seen many of these ring-enhancing lesions that I have shown you, but all of them, if they are infectious in origin, will have negative perfusion. So in these things where you're uncertain, it's better to do perfusion-weighted image because this immediately will exclude majority of necrotic tumors. And then you go actually one by one. This will be diffusion, right? Diffusion will be elevated here will be restricted in the wall, here in the center, and here it will be elevated. Then you add SWI, or spectroscopy, and then you will have a diagnosis. This is your thinking cascade. So with perfusion, you excluded immediately tumors, and then you go one by one, looking at the sequences to get into the correct diagnosis. So basically, conventional sequences provide a quick guide, you know where you are, and then further differentiation, you use advanced techniques. Okay. So this is my roadmap. You need a roadmap. You remember at the beginning I said you need a thinking cascade, one by one. Roadmap goes like this. If I have a patient, I will always go back first to T2 sequence and see what is the central looking like. Then you do diffusion, perfusion, whatever you want. Then you look like this. I don't know in South America if you look Dr. House, I love him, he's so funny. So Dr. House sometimes look like this, and this is how you will look like if you want to diagnose infectious diseases without some information. What will you need? You need some clinical information. No matter how good you are in analyzing imaging, you go one by one and you are perfect. At the end, you need a clinical information. You need to know, or in very questionable cases, you will get out of your dark room and you will look at the patient yourself, but only exceptional cases. Okay, let us look at this case. This is my favorite case to show because I made a mistake. So this was a young girl. She was 14. She was having headache, hemiparesis, seizures, but no other history. They called me, the pediatricians, and said, Dr. Turner, what is this patient having? I said, oh, this is very easy. It fits to my roadmap perfectly. Ring-enhancing lesion, a little bit, let's say, inhomogeneous diffusion, negative perfusion, so it's definitely not a tumor, and it's hemorrhagic. Which ring-enhancing lesion is hemorrhagic initially? I said, this is fungal abscess. Okay, they said, oh my God, fungal abscess. Then they called me back and say, this is not a fungal abscess because she's not immune suppressed. And then I said, this is your problem because images are not lying. It really fits to the analysis. So it must be a fungal abscess. It cannot be anything else. So again, I went back. T2 is dark and inhomogeneous, diffusion, perfusion is negative, it's hemorrhagic. What would that be? It's probably not toxoplasmosis, she's 14. And then I keep asking them, give me a medical history, give me something, look at this child. And then it turned out it's a pyogenic abscess due to Streptococcus anginosus. I was really disappointed because I'm teaching this in all the courses. So if I'm teaching this and I make such a basic mistake, how can I trust what I'm talking to people? Well, then I said, I just don't believe this. It must be something that you did not tell me. And it ended out she's having a heart disease. So in rare cases, but now in really rare cases, so pyogenic abscesses will be initially hemorrhagic in patients with heart disease. So you see, images don't lie. This is the second case. I think I had this case like a week later, which is usually typical because you have a series of cases. This was a 30-year-old male. He has a double inlet left ventricle and some other problems, headache, concentration difficulties. This was a CT. It looks like something, a lesion here. It's difficult to see what it is. Then we did MR and said, okay, now we have again a ring-enhancing lesion, which is obviously hemorrhagic. In this time, we said, okay, this is something with a heart disease. This could be a hemorrhagic pyogenic brain abscess. And in this case, we were right. So it's very important to ask clinicians because I assume that they don't write so many things on the referral sheet. So my list to ask for list before you say something is this an HIV patient on therapy or not? Is this an IV drug abuser, organ transplant BMT, Is this patient on immune modulation therapy? Is he from endemic region or any other region that you don't know? Or was this patient traveling? So this information you will need for the diagnosis. So the last part of my presentation, I don't know how much time do I still have. I have selected several cases. So the analysis that I have just taught you, we will have to go one by one. So this is case number 1. It's a ring-enhancing lesion. Here is thin, here is a little bit thicker, right? It has some kind of edema. It's elevated diffusion. So immediately we know it's not a pyogenic brain abscess. It could be a lot of things, but here we can exclude pyogenic. Then you look at perfusion. Here is okay, a little bit green, but then this part, which exactly corresponds to this thick enhancement, is very red. So now this is too much for a collagenous capsule. So this I would call increased perfusion. And then you see SWI, which in this case does not show much. So this is clear, this is glioblastoma, cystic glioblastoma. So what I wanted to show you with this case, this red doesn't have to be everywhere. It's always there when the thickest enhancement is. So this will be a cystic glioblastoma. This is another one. Well, that's an easy one. This is a ring-enhancing lesion here on the right side. It's here close to periphery. It's bright on T2, dark capsule. It has an edema. It's bright on diffusion. So right here you start thinking bright on diffusion. This is probably pyogenic abscess. But to be sure that it's not metastatic disease, we do perfusion. You see, perfusion was negative, so this is clearly pyogenic brain abscess. So you go one by one, and each sequence will help you to exclude certain things. Is that clear so far? Claro? Todo claro? Okay, then I keep on going. This is case number 3. Case number 3 is this, okay? It's a ring-enhancing lesion. Here it is with a huge edema. Okay, here, I don't know really. Can this be pyogenic brain abscess? Let's just imagine you don't see this. When somebody asks you, is this bacterial? Then you immediately go back to T2. It's too dark on T2 centrally. That cannot be bacteria. It doesn't look like bacteria, but let's keep on going. Diffusion is also not really restricted, and it has a red rim here at the periphery, and here a little bit line, but not complete. So this must be positive perfusion, ring lesion, dark on T2. This is obviously metastatic disease. So perfusion actually helps you to distinguish from infectious lesion, and this T2 definitely showed you this cannot be bacterial abscess. You agree? Yes, okay. This one, it's an ugly looking lesion. We can't really call it ring-like. Let's say peripheral enhancement. It has a restricted diffusion. It's relatively dark on this ADC, but this doesn't look like an abscess. But you never know. You can never be sure. Let's say without even looking at anything else, you have to look at other parts, even without perfusion diffusion. Don't forget, this patient had this and this. Do you think that this is a pyogenic brain abscess? No, because in combination with this, logic is still logic, with confusion or diffusion or not. So these are certainly multiple metastases. So this was one of these examples of a hypercellular metastatic disease. So again, don't call something that is bright on diffusion and peripheral enhanced immediately brain abscess. Be sure that you have seen everything. This is a case that I got from Professor Tali from Turkey, and it's a nice case to show how the analysis should be done. 40-year-old female, so let's say middle age. No, let's call it young. Headache, middle age, I always tell this, middle age is 10 years older than you are, right? So headache and increased intracranial pressure. This is this huge lesion. Immediately you see lesion is very dark on T2 with a lot of edema, even a little bit bright on T1, peripheral enhancement. Can be tumor, can be infection. Okay, we have perfusion. Turgut cut it a little bit, I don't know why, so it was negative on perfusion. So what do we know? It's probably not a tumor. It's not a glioblastoma, it's not metastatic disease. So let me show you again so that we have practiced it several times. T2 means dark on T2 means high cellularity, means bacterial abscess immediately excluded. So only by looking at T2, it's not bacteria. Then T1, it's enhancing. It can still be a tumor, or an abscess, right? And then perfusion is negative, so tumor is excluded. So I have excluded bacterial abscess, I have excluded tumor, so I still have an abscess. Obviously, it is infection, but it can be TB, fungal, or parasitic. Am I right about that? Do you agree? Yes, you agree with me. So you see, one by one, we excluded things. So now I have to know TB, fungal, or parasitic. So now I was joking with Professor Tali, and I took this image, so this patient was coming from Turkey. Now you have to know or to Google what is endemic in Turkey. So anyway, this could still be TB, this can still be parasite, and it ended up to be alveolar echinococcosis. And this is the beauty of our life. You know, first I was teaching you that alveolar echinococcosis has a grape-like enhancement, and then it's looking like this. So you see, you can learn and find the patterns, but still there will be these beautiful cases. Okay, can we still going? You still? Okay, no beach? Who wants to go to the beach? And who wants to see cases? Cases, good, okay. Okay, this was another story, because if I tell you a story, you remember. This was a guy who was psychotherapist, and he was brought to the hospital by his wife. And we were asking her, so what's the problem? And she said, oh, he's crying with his patients. And we thought, like, that's called empathy. This is what he's supposed to do. He's a psychotherapist. What's the problem? She said, no, it's definitely something wrong with him. Okay, so we did CT first, and on CT we saw a ring lesion. And the general radiologist and me were on call, and he said, okay, let's immediately do chest CT and abdominal, because for him, brain lesion is a metastatic disease, so he's looking for primary. I said, well, give me this patient. This is now my patient, and this patient goes to MRI. So this was the lesion. Several layers, dark, bright on T2, very thick enhancement, but negative on perfusion. So what we know by now? It's probably not a tumor. It's not a metastatic disease with such a thick enhancement, but nothing on perfusion. Just doesn't make sense. It's very bright on diffusion, low ADC, and dual Rim sign. So this is a perfect bacterial brain abscess. It was a pyogenic brain abscess. And then we talked to the patient again, and then he said, yes, he's having a recurrent mastoiditis. And then we looked back at the CT, at the bone window, and then we saw, oh my God, we didn't even need MR and all this sophisticated thing, because we could see the destruction of the mastoid and the infection going up. Okay, this is this ring open or closed? Open. You see here it looks like huge enhancing lesion, peripheral, with elevated diffusion. So what I know here, it's not bacteria. It's a big thing, but it's not bacteria. And then you look at the coronals, and then it's open here. Why would pyogenic abscess be open? Organism reacts to the organ, and then around it built a capsule, and capsule goes all around. And even more, you see edema. How is this? If this is a brain abscess and the edema is not so prominent, this again doesn't make any sense. So this was tumefactive demyelinating lesion without any other sequences. So now you tell me, what would perfusion look like in this case? Positive or negative? Negative. So tumefactive demyelination lesion have low perfusion. Okay. This is an HIV positive patient, another case, and there's several lesions. Okay, first you look at this, and then you go like, oh my God, what is this going to be? And then you count down, and then you go back. Which first sequence you go back if you have? You go back to T2, very primitive T2. I don't have T2, I have flare. And now you look. This is all enhancing, but when you look at the lesion itself, they're usually dark. All this bright is edema. Lesion itself, the part that is enhancing, is dark on flare. First thing, so it's not bacteria. Secondly, they're ring enhancing or nodular enhancing. But the most important in this case is the location of the lesions. Location, I mean, are they in the white matter or gray matter or cortex or middle? Where are they? Now, if you look, they are located in the cortical region, somehow at the periphery and a little bit basal ganglia, here and here. And we know now, HIV patient, immune-suppressed patient, dark on T2. What is dark on T2? TB, fungal parasites. And now cortical location, this is fungal infection. Remember, fungus like the cortex. They love the cortex because in the cortex they have a lot of vessels. This is a case of a patient with several lesions, and this is confusing because lesions look different. It's always good if all the lesions are bright, all the lesions are dark, but if some are dark and some are bright, this makes a little confusion. Let me show you this case. So here is a lesion, here is lesion, here is lesion, relatively dark on flare. This one is ring enhancing, this one is nodular. Well, that's not so difficult. Sometimes lesions, infectious lesions, when they are small, they are nodular, and they're getting bigger, they get necrotic, and they are ring-like. But then diffusion was so confusing for us, because diffusion was restricted in this big lesion, but was elevating in the smaller lesions. So you think like, is the big lesion different than the small lesions, or what is this exactly? Okay. That's another. Does it mean that you want me to stop? No. Okay. This is T2. Remember I said we should go back to T2. They're very dark. So are they bacterial abscesses? No, I think we got that. This is not good for bacterial abscesses. And this is now the spine of this patient. I'm sure, how does this look like to you? What would you say looking at this spine? You will say tuberculosis, and you will be right in 90% of the cases. So now, what is the major differential diagnosis to tuberculosis in the brain and spine? Which other infection? Exactly, brucellosis, which you will get if you eat some strange cheese. So now we'll learn the lesson. If it looks like TB, but it's not TB, then it's brucellosis. And I have looked at the literature and couldn't actually find anything about a diffusion in brucellosis lesion, and when you find something, they can be restricted or elevated, again, depending on the content. This is a patient who was after, I think 2 months after organ transplant, he came in and he was having this lesion here, the frontabasal region. It's restricted, it has a low ADC, it has some kind of a dots, obviously a little bit petechial hemorrhage, and then it was not enhancing. So now, what is the most common thing that this patient will have, especially in the frontabasal region, especially if they have also problems with their paranasal sinuses and they're immune suppressed? Do you still think of an infection? Yes? Yeah? Infection, although not enhancing. This was 1 week later, it's starting showing some kind of enhancement, and this is 3 weeks later, it's starting to be very big and hemorrhagic. So this is fungal disease, definitely this was invasive mucormycosis. Some of these cases are really challenging. As I said, you think that you know everything, you analyze everything, and it still doesn't fit. This is also a case from Leonardo Macedo, one of the great young neuroradiologists from Brazil. Gave me this case, ring enhancing, edema, it's bright on T2, it has a dark capsule, it's here, on diffusion, diffusion is elevated, and then perfusion. Okay, and then you look at this perfusion. In the wall here, the RCB values were 3 times higher comparing to the normal contralateral white matter. So now you tell me sometimes these extensive measurements of little things can be more confusing than just by looking at things. But still, we said it should not be red. It should be just a thin rim of enhancement. Okay, so was it a tumor? It doesn't look like a tumor, but this perfusion was very confusing. I will zoom this for you. You see, this is how it looks like, and then all of a sudden this part was very red. But still, the clue sequence was this one. Do you see these venous structures running through this big lesion? So this is definitely, despite of a very localized increase of perfusion, a tumor-effective demyelinating lesion. What I wanted to say with this case is sometimes not all the sequences will fit what we just learned, and you will have to make a decision based on some clinical information. Do I still have time? Rahel, you know that? Yes, I do. Okay. So this is a little bit easy case. This is a ring-enhancing lesion on the left side, bright on diffusion, negative perfusion, just a little bit, dual rim sign. So this is now this is a no-brainer, right? Is that how our American friends call these cases? No-brainer, where everything fits. and it's easy. This is pyogenic brain abscess, right? This time everything fits. Okay, this is a case of an immune suppressed patient again. There are lesions here, and it looks like it's enhancing, and a little bit, to me, it looks like the organism would like to produce enhancement, but cannot. So you see a little bit, but not much. It's bright on diffusion, so you might think, can this be bacterial? But for bacterial, it doesn't look so nice on this flare. It's too dark, and then it has some petechial hemorrhages. So this is an immune-suppressed patient, relatively dark on T2, hemorrhagic with restricted diffusion. This is fungal, exactly. This is a fungal infection. So you see, you always combine the little pieces. This is a huge one, again, a lesion in the frontal lobe with several layers here, inhomogeneous ring enhancing. You add perfusion and SWI, and this ended up to be pyogenic brain abscesses. So you see, everything was good until SWI. I just told you today you should see a dual rim sign. Be careful, not always you will see a rim sign. If you see it, it will speak for pyogenic brain abscesses. If you don't see it, if you sometimes see these things, it doesn't mean that you can exclude bacterial brain abscess, because all the other sequences were fitting to bacterial brain abscess, and this patient was drained also. And now the last case, now you tell me what this is. This is? No? You don't want to tell me what this is? Of course, yes. This is, I would need some help, like something like this, like Dr. House has, to diagnose this cysticercosis, but I'm sure you know that. This was my last case. I thank you very much for listening. And I hope I did not confuse you more than teach you with all these rings.
Como les dije, estábamos aquí para una Master Conference por la profesora Magda Turner, y si hay algunas preguntas que le quieran dirigir, pero antes les voy a decir que para la siguiente exposición, después de la pausa, aquellos que quieran participar en las preguntas y respuestas pueden subir la aplicación con la ayuda de nuestros asociados en el Departamento de Audiovisual. O sea, después de las preguntas a la doctora, vayan y pueden subir su aplicación para la siguiente presentación y las respuestas. ¿Preguntas para la doctora? Sí.
¿La hago en español o no? Inglés. Thank you very much for your big effort to teach us about all these differentials. I have two questions for you.
Two, already
First,
two.
the classic one. In which way you use to differentiate today lymphoma from toxoplasmosis? And the second one,
Yeah.
can you rely on ASL for perfusion?
Okay, first question. First,
Okay.
how can distinguish lymphoma from toxo? We still can't really very good. Is that the answer that you were expecting, or you expected a new sequence? We still go with the whole brain tumor imaging protocol, and then they go for PET, if we can have PET immediately, and still give a therapy, and after 10 days repeat. So none of the sequences is 100%. Some people like nuclear medical techniques. I don't so much. I don't have an impression that I can do this. I try to rely on location. You know, something periventricular going around the ventricle, then I say lymphoma. But I don't think that this is what you were asking me. You wanted, you know, the classical multiple ring enhancing lesions. So I can't give you any good answer to that. We do everything, and then we describe. Perfusion will be negative in both. T2 will be dark in both or bright. So you can't really, diffusion can be positive or negative. So there is no good answer to that, unfortunately. A second one, ASL, I don't do much ASL for this infectious lesion. We don't do, so I can't answer this question. We always do contrast enhanced normal perfusion. So ASL, a little bit for tumors, but not for this infectious lesion.
¿Alguna otra pregunta para la doctora?
As you said, Magda.
Yes, the history of the clinical history is very important. Yes, I understood that, yeah.
Otherwise, it is for us very difficult. That's again the importance of us always talking, la importancia que nosotros siempre hablemos con nuestros médicos que nos refieren pacientes.
If possible. if you can find them that day. Usually they are not there, nobody knows anything about the patient.
Muchas gracias y después de la pausa los esperamos acá para la tercera sesión.